I'm recording. Great. So I'd like to start off today with the territory acknowledgement. I live on the traditional territories of the Lekwungen-speaking peoples of the WSÁNEĆ, Songhees, and Esquimalt nations. And our work here with the West Shore AVI focuses on the West Shore region, which serves the traditional territories of the Sianu, Sauk, and Pacheedaht nations, as well as Greater Victoria and the Lekwungen-speaking peoples territories. This is important. Territory acknowledgements are an important step in decolonization, but we also recognize it can't stop there. There is a lot of lip service and talk being done about these things, and a participant actually in our Peer Power project mentioned attaching an action piece to doing the territory acknowledgements, which has gotten me reflecting on what I can do in my future work. So I've devoted a fair amount of time learning about the health inequities that Indigenous people face due to colonization, and how colonization is ongoing and continues to perpetuate those health inequities for Indigenous peoples. In my future work, I'd like to make more of an effort to reach out in a culturally safe way. So recognizing that's often like going, the tools of communication might be different. And it might be trying to connect through different community members who already have relations, and really kind of learning about the kinship systems that already exist, and trying to support those. So I hope that makes sense. So we're very grateful, very honored to be able to present this forum on the traditional territories from West Shore AVI. Something else I want to mention, logistical piece, is the gift cards. So we do have little polls going through the day, but when we talk about gift cards and how you can enter to win the draw for a gift card, it's actually from the evaluation that we're going to send at the end of the day. So we'll get that to you after our day ends, and you'll have until Wednesday to fill that out and to be entered into the draw. Yeah, without further ado, I'll hand it over to Sage to introduce herself.
Thanks, Jenny. Thanks everybody for being here. I really appreciate everyone coming back, and if you weren't here yesterday, for coming today. If you would like to put the territory that you're coming from, that would be super awesome. If you want to put that in the chat, if you know where you're coming from, that's always so appreciated. And yeah, if you want to introduce yourself or ask questions or anything, just like yesterday, if you were using the chat, that was super awesome. And also unmute yourselves and talk, that's also great too. But yeah, so hi, I'm Sage, she, her pronouns. I am the Peer Power Facilitator, and I'm really happy to be here today. I cried yesterday multiple times, and I also danced in front of everybody. So it was a really great day for me. I did the 2 of the 7 ways of natural healing, so that was amazing. So yeah, I had a good sleep, so I'm feeling good. And I'm super excited to introduce our first speaker of the day, Douglas. Douglas is an experienced Hep C researcher. He is currently studying applied theater at UVic, and he's very passionate about all of his studies, and is super, super knowledgeable about Hep C and just everything that he talks about and is passionate about. It's awesome. I also want to say that he does have a robust history of community-focused hepatitis C outreach and advocacy efforts, and he was the past director at large to Action Hepatitis Canada's steering committee, if that's correct. So without further ado, I'd like to turn it over to Douglas, and he's the co-host, so he can share his screen. Awesome. Okay, just checking.
Well, thank you, Sage and Jenny, for your work and your meaningful support as well. And to start with the habit of making gratitude lists to help appreciate myself in the process. I do want to recognize with gratitude that I am living on land situated on the unceded and traditional and ancestral territories of the Lekwungen speaking peoples of Esquimalt, Songhees, and Masonic nations. You know, and maybe for another day, I do have my own personal pain from the experience of residential schools. And with that, I'll leave that for now with all my relations. So as I start sharing my PowerPoint here, how to make this bigger.
Go to slideshow. Yeah.
Slideshow, okay.
Yep. And then from beginning.
So I decided to call this talk about the science and the experience and alarmist warning. So, and I just learned yesterday that they now have a name for Hep C associated neurocognitive disorder. Yeah, so to begin, I wanted to start with some of the research that kind of contextualizes what's going on with stigma in Hep C. This is from a study in 2016. It's a phylogenetic study that traces the genetics of the Hep C virus, where they found that, you look at the y-axis at the bottom, going back to 1940, that during World War II, they pooled blood products for plasma. And this is an underestimated factor in the spread of hepatitis. You know, the common belief is predominantly attributed to drug use, and it's largely blamed on people with addictions spreading it. But the reality is the spread of Hep C started happening a long time before drug use was. So I'll just say that in Canada, we have about 1% of the population is infected by Hep C. But in the US, it's up around 3%. And this again is because of the Vietnam War. They inoculated people from jungle diseases using the same needle. And so the spread of hepatitis C is a byproduct of war, and of course the war and drugs has also helped it proliferate. So again, going back a bit, this is from a study in 2010 in Ontario that was underway, and some hepatologists were asked to contribute, and they said, hey, wait a minute. You're calculating hepatitis C deaths without adding in liver cancer, and Hep C and Hep B are causal in liver cancer. So, and it was, very frustrating being an advocate and dealing with families who had family members dying of Hep C, to all of a sudden the coroners would say, oh, it's not Hep C, it's liver cancer. So when they refactored in those calculations, Hep C is the leading viral cause of not just deaths, but health-adjusted life years or disability years. Also a footnote here, Staphylococcus is often spread through crack pipes. And so just thought it's interesting how much harm reduction has helped reduce the incidences of not just Hep C, but other viral diseases. So I decided not to go into a full explanation of all the things that Hep C causes. But these graphs show the reduction in some of the what we call extra hepatic manifestations, other things that Hep C does to you: diabetes, liver disease, stroke, and heart disease. So the bottom line on the graphs is the reduction of these extra hepatic manifestations once hepatitis C has been treated. So it's a good news story. It takes a while, a lot longer for things like heart disease and rheumatoid arthritis to be positively affected by treatment. And mood and anxiety disorders, I'm going to talk a bit more about the controversy. This is from study the persistence of neuropsychiatric impairment in hepatitis C patients despite the clearance of the virus. This is a German study. I talked to the author of this and brought it up at one of the Hep C conferences. So what we have here is 5 groups. Of course, the control groups are people who never have been affected by Hep C. The red group is people who are positive for Hep C and who have been through interferon treatment. The early treatment was quite brutal, so there was a lot of complaints about the damage that the early treatments did. I spent a year injecting interferon 3 times a week, and thought that was quite interesting that, that group doesn't do so badly. So then people who are negative they've been treated through interferon do a little worse. People who are positive for Hep C but haven't been through the treatment, again, are a little worse. But the interesting group here was the people who are spontaneously cured. So they have the antibodies and they have not been through interferon treatment, but they do worse in several most of the categories. So this is still inconclusive. It's not like a lot of viral infections will cause metabolic changes that are not good, and those metabolic changes persist after the virus is gone. So and this is significant because what's going on with, I'm not getting the next screen up here. Not sure what's going on here. I can't move to the next slide. I'll try that again. Any ideas?
You might have to go down to the left corner. There's little arrows. If you see like left corner underneath, yeah, and then click on the next arrow. Does that do it?
There we go. Okay. So we talked a bit about spontaneous remission. There's a study done in last year that shows the NAINS study is a large American study that this is the rate of spontaneous remission from hepatitis C. We used to say that it was around 15 to 20% of cases here in North America. But this study is a meta-analysis of a study. So showed that the actual rate of spontaneous remission is closer to 35 to 40%. And in some countries like Brazil, it's over 60%. Vietnam, it's over 50%. And then again, Mel Krajcin crunched some numbers in the bottom right chart. It compares the people. So what we have here is Hep C negative average deaths, and then people with Hep C die around 56 years of age. But then the strange thing is that they found people who are spontaneously cleared also have the same reduction in lifespan. So we don't really know why that is. It may be that there's some confounding factors because people with Hep C tend to live riskier lifestyles. You know, but I've always been really intrigued by that because of the neurocognitive damage and what that might mean in these numbers. So I was really nervous to present my poster at the conference, but suggesting that these neurocognitive factors were significant in the overdose epidemic. Then about 2 weeks after I submitted my abstract, there was a study that, and again, a meta-analysis of a lot of biological studies. This suggested, like they've done PET scans, which is an expensive radiological tracing scans in the brain for people with Hep C, and found independent of liver disease and independent of viral progression and drug use, that there was some damage in specific areas of the brain, one known as the Basal Ganglia area, region. And we know that various regions do certain tasks, and the basal ganglia is where we differentiate, where we have processes called procedural categorizations, and it's where our schema, like our schema is what we think about ourselves, as well as, you know, if we want to go out for dinner, we know there's certain things involved, and we have to plan, like put our shoes on, go out the door, go get to the restaurant, sit down. So all that takes place in the basal ganglia, along with other things. So anyways, yeah, seeing this study helped me relax a bit. So this month, actually, there was a new study. Again, you know, our friend and supporter, Mel Cradgen, who leads Hep C at BC CDC, and others, looked at this issue again. Like, so we have a complicated graph here. So these are deaths per 1,000 people. On the other side, it's total overdose deaths. So the bar graphs, the bars here are liver-related deaths, and the lighter bars are drug-related deaths overall, going through the years. So we have the light gray, which indicates liver-related mortality, people who are positive with Hep C, and so this dark bar is the drug-related mortality in the people who have Hep C. So there's a significant jump. This is the next graph. We finished with that graph. So this, the data suggests that it's largely men with Hep C who are seeing an increase in overdose deaths. There is a jump as well in women, but I mean, it's significant, jumping around here. So yeah, pretty alarming. There's potential for a lot of confounds. How are we doing here? Can you see that? Can you see everybody's faces here as well? Wondering if I should just get rid of that. So just to talk a bit more about the areas affected are largely in the inside of the brain, in an area called the limbic system, and these are what is called the basal ganglia. The caudate nucleus and the pitumen together, they make up what's called the striata. And it's kind of like a switchboard. The information comes in from the prefrontal cortex, or the command and control, the decision-making area, goes in through the basal ganglia and then out again into the thalamus and hippocampus. It's where memories are formed. And so I'm trying to figure out where I am in my notes here for a minute. So these are actual brain scans, and the gray matter atrophy. Gray matter is basically relates to brain power, I guess. That's also tissue that interconnects different areas. And you can see that there is a significant reduction in gray matter atrophy after a long time hepatitis. So 50 to 60% of people with hepatitis C virus have fatigue as the leading syndrome. And this is followed by depression and anxiety. So I kind of use fatigue as an indication, like if I'm talking to somebody and they say they have fatigue, well, that's a good indication of a neurocognitive. And back to the point where, in spontaneous remission, I think it's important to note that only 20% of people who obtain SVR, which is a cure, the term we use for cure, spontaneous viral response, those people still have significant fatigue problems. So what does that mean? And as peer supporters, there's now a push for us to help with, especially with harder to reach populations, in addressing this, the prevalence of hepatitis C. In BC, there's approximately 80,000 people estimated to have hepatitis C. And this graph is what we call, what is referred to as the Cascade of Care. So BC Pharmacare has all these things they want done before they'll give you the treatment, this miracle treatment. It really is a miracle to have such high response, a cure rate with minimal side effects is really a biological anomaly. It's a miracle, really. But so in order for their requirements, we're, that every stage of this cascade of care, first off, is the antibody. Then once it's cheaper for them to test for antibodies, and then to move on to the RNA tests. The important thing about this graph shows is that of all the people that get diagnosed, when they're asked to do the confirmation test, we lose a significant proportion of this population to care for one reason or another. So, they go on, could get confirmed that their RNA is positive, and then they're asked to do a genotype. This genotyping is due to COVID, has been postponed for now. So I did a presentation to Pharmacare to ask them to not just leave that requirement off the list, but temporarily, but permanently. And so, we get down a little further, and you see the amount of people who achieve SVR is really quite low, like 20,000 people. Like, we're about a quarter of the way. So as peer support workers, I think, the difficulty with a street-involved population, that testing is going to require our work and our contribution if we're really going to meet the Canada's commitment to the United Nations goal of eliminating hepatitis C by 2030. We are going to be an important part of that. I wanted to pay a bit of homage to a couple of local studies. Ashley, many of you might know Ashley's longtime work with local organizations, and But the people they worked with on these studies, you know, were people, the people who were affected by Hep C, homelessness, and marginalization, and you know, people are dying, they're getting kicked to the curb, and there's no services for palliative services for a lot of these people. You know, it's really hard. I've found it difficult in my own experience to be able to make a living, and even the course of my degree in psychology, I wanted to be a biological psychology major, but that procedural categorization, I found it was very difficult to do biology in a lab, and so I had to adjust that. And I've constantly gone through jobs because you know, I'm a baker, I'm a cook. I just you know, I was making a large batch of chocolate chip cookies, you know, and out of nowhere, I pulled a box of carrots and threw it in my mix. And this is the kind of thing that happens, you know, that affect your ability to survive, to make a living, to do the things that are important to your self-worth. I have found some things that help, and I go through a list. I've made this presentation so it's printable, so if people want to print out any of this stuff out later. One of the things I've been taking for over 10 years is something I find in the drugstore, health food store. It's cheap. It's called N-acetylcysteine. It's actually used in medical practice to counteract liver damage in acetaminophen or Tylenol poisoning. And it has some preventative aspects, prophylactic qualities in preventing of cancer. And I found it also prevents depression, one of the other side effects. So yeah, liver cancer is usually what causes death. Lots of people go through long-term hepatitis C with zero side effect or zero symptoms, until when I've had lots of friends wake up and realize that they have liver cancer. So it's a really traumatic event. The rates of the diagnostic processes are really abysmal. So, you know, if people who are stage 3 or stage 4 fibrosis really need to be monitored for liver cancer 10 years after they're cured. So NAC itself converts to an antioxidant, and it also probably, you know, antioxidants are one of the major defenses, nutritional defenses in hepatitis C, because fibrosis is actually the immune system attacking liver cells. And so oxidization is important in that process. So yeah, so what is SAMe? This is really incredible. Also found in the health food store. It's useful in severe depression. It's used in Germany Spain and Italy is prescribed there. So in my experience, it can cure severe depression in a few hours. But there's some caveats, and particularly it might be dangerous for people with bipolar disorder. Other caveats, like you should always buy it in a blister pack, because if it's not protected from oxygen, then that's going to wear down its antioxidant capacity. It has low bioavailability, so I always take it on an empty stomach with water. I take, it comes in, the blister packs are 400 milligrams, so usually two, like 800 milligrams works for me. And I tell you, this is incredible because I can actually feel the depression lifting immediately. And this is the type of depression that is long-term and persistent and goes on for months and months. So it works up to 45% of the time. It doesn't always work, but again, like the body needs certain things to make it itself, and it's important in the energy, the cellular mitochondria. Anyways, don't take it if you're on SSRIs, because SAMI actually produces serotonin, where SSRIs make it stay around in between the synapses of the neurons. So I've tried it. Just I'm always the guinea pig for things like this one. You definitely notice. So it's expensive. It's about $80, but you don't need to take it for more than a couple of days. So tryptophan. This I stumbled upon. Again, it's important in the metabolic mitochondria. The fatigue is one theory that fatigue is caused by at the cellular level, and tryptophan is a major component of that process. So I started taking it to help me sleep. Hep C does cause sleep disturbances. So, and I was surprised that I haven't been depressed or had any depression problems since I started. So I can also use it just one pill for anxiety. I was hoping there might be some reduction in fatigue, and it hasn't really worked out that well. I still have what is called systemic exercise intolerance. So if I do something physical, half an hour later, I go into this fatigue that I cannot stay awake. The other thing I wanted to talk about briefly is one of the more effective therapeutic techniques is cognitive behavioral therapy. And it really doesn't require the 4-hour CD set mindfulness meditation to train yourself to stop self-effacing thinking. This is where I find, as a shame-based person who's experienced trauma in my formative years, that this shame-based thinking is my go-to place. My system naturally reboots, and I find myself in self-effacing thinking. So I'll recognize it, and now that I've had a bit of practice, it gets easier and easier to do. So just to walk through a bit on this process, I I recognize the thought, and I call it a hot thought, which is any negative statement about myself. And it can be helpful when you're learning to write it down. So there's lots of worksheets. You can Google CBT hot thought challenging, and you can find these workshops. So in the next column, you write down ideas that challenge that hot thought, and you can often see that the thought itself is it doesn't have any foundation. It's just, and then you start to challenge it. So and coming up with more self-appreciating thinking. I'm not sure. I think that's my last slide. I should have mentioned anybody welcome to interrupt or any questions, but that's probably a good time to ask any questions, or is there anything that, I hope that's all clear enough, to constructive enough.
Yeah, if anyone has a question for Douglas, feel free to unmute yourself or put it in the chat.
Douglas, thanks so much for that. Those factors or reasons why some of that data is so interesting. Hey, and it would be amazing if we had that insight as to, the causes, because if some of those causes could then be addressed, because there's clearly some real interesting findings, isn't there? That's more of a comment. My question is, as it relates to the suspended genotype testing during COVID, which I think is a good thing, at PAN, we're wanting to advocate to continue that, right? Because from what I understand, it has its clinical applications, but it can also prevent somebody from moving forward in that cascade of care. I'm trying to learn more about that special authority form surrounding the genotype testing. Do you have any recommendations of how I could research, like, the details of it and who signs off on it and things like that?
Yeah, the people at PharmaCare have, for the last 10 or 15 years, have always been a source of frustration with their requirement for these testings, and but they're also open to conversations about this, and the advantage that we have moving ahead, I think, is that we have dried blood spot testing coming online, and as the goal, of course, is to have one kind of somehow missed this part earlier, but in Prince Edward Island, they've had same-day treatment starts, and have virtually eliminated Hep C and PE Prince Edward Island. So every province has its own requirements for these tests. Ontario has been a little bit more successful in testing in sites where you can use supervised injection sites, right? So that is kind of the goal, to train peer support workers to do dry blood spot testing, and that's for the antibody. And of course, we have in the near future, we'll have approvals and the process for what is called point of care testing, which actually gives you whether you're RNA positive for active virus within 20 minutes to an hour. And, you know, in the best of all scenarios, I think that if peer support, I don't know if we're going to get there, but if peer support workers could give that person the drug right there and start them on treatment, then we're going to have a much more effective cascade of care. And so I think like that's what we're pushing for as peer support people. But I think the scientists are also behind this as well. And they're doing, Mel and Sophia Bartlett and Naveed, and you know, they're really pushing for this, the research to support this trend towards diagnosis at safe consumption sites, and potentially even same day or same week treatment starts. I hope that answers your question.
Is there a connection between dry blood spot testing and that picture of the genotype? Like with dry blood spot test, would that sort of increase the time in identifying genotype or not necessarily?
Not necessarily, no. So I don't know how many years ago I did another abstract and presented. They do have the technology for, you know, it's one of the incredible things about advancing medical science. We have something called proteomics. Victoria actually has some of the world's largest collections of research data in proteomic research on strokes, which is another, you know, I piqued my interest because strokes are a big factor. Hep C causes arteriosclerosis, which is a buildup of plaque, and so we have higher incidence of stroke. So anyways, they were doing some work locally with proteomics, which is it's a machine that they used to cost hundreds of thousands of dollars, but now they're down to they're still expensive, but desktop size machines, and they take a blood sample and put it in this machine with a chip that asks the machine to look for plasma proteins, and they can tell things like genetics, the gene structure of various hepatitis, but I don't think we're going to get there, and I think that we might just have to drop genotype testing altogether if we're going to hammer this epidemic as quickly as possible. Everybody's curious about all these things, but just for the efficiency of getting people cured and eliminating the virus, because with, you know, my concern with the opioid epidemic and is we're getting growing numbers of young people who are getting infected, and especially, you know, this you know, this new data on potential mental health effects of people who spontaneously cure. If this is true, this is like huge, because people don't have Hep C and awareness, and so, you know, you go to you have problems, and you get diagnosed with all these sophisticated mental health issues, and you know, it really is coming down to the biological effect from hepatitis C. So, you know, again, I probably skirted around your question, Monty, but it's a great question.
Oh, thank you so much. I think, you know, the key thing that stood out, that PharmaCare would maybe be open to a conversation. So it's always worth me maybe, you know, just reaching out and prepping a little bit and, you know, kind of approaching it with the spirit of, you know, I'm wanting to gather information and kind of come up with a, you know, a suggested, you know, solution, and be open to their input too, like maybe reasons why it hasn't changed up to this point. So thank you.
Yeah, and I think like right now, like there's a requirement for liver enzyme tests before you get approval for treatment. There's ALT, which was, you know, people, it's an indicator sometimes picked up on general blood tests that suggest that there's a problem in the liver. But they've got AST, which is another not so important liver enzyme as a requirement for tests. Now, LifeLab blood requisition forms don't have separate boxes for AST, and they don't have the specific check boxes for whether you're doing Hep C RNA or whether you're doing Hep C antibody. So these are other problems that are coming up. So, you know, a doctor who's just a GP and he ticks off the Hep C box, it doesn't specify which Hep C test. So then that client gets lost because they don't have the right results coming back and they have to go again for another test. And the same with AST. Now, what the hell? There's, you know, might be reasons for testing AST that are very small, and you know, we know we've collected a lot of data already. It's just really frustrating to get to have patients wanting to get going, motivated towards treatment, and then constantly having to go through all these hoops. So yeah, it's an ongoing work in progress.
You said, Douglas, that your slides, we could print them off.
Yeah, I can. We'll figure that out. How?
Yeah.
Yeah.
That would be great, because then maybe if folks want to research or read the papers that you shared, we can share those slides with folks after.
Yeah, I'm just thinking of the last. I could have put a last slide. I think motivational interviewing is going to be an important part of training peers. You know, some of the big pharma are on the line right now. Like they've offered to provide point of care testing for use by peer support workers, and so, you know, everything screeched to a halt with COVID, but as things start to move ahead, all these pieces will fall into place, and I think that anything that involves peer support, supporting peers in their work, is going to be great.
I agree. Does anyone else have any questions before we take a little break and come back for a discussion on hepatitis C?
If we are able to post a link of those slides in the Google Docs, if they become available, we can put them there. And I don't, Sage, do you have the link for the Google Docs?
I do.
And you could
Posted
post.
it.
Okay, sweet. same as we used yesterday. If you want to share any information, there's a link there in the chat. You can go add some stuff.
Yeah.
Yeah, I hope to put a website together, and it'd be nice to have all these studies because they're fascinating reading. If anybody's interested in neurology and biological psychology, it's there's an overwhelming amount of evidence. And it's like the dopamine circuits and how addiction changes how the brain functions has been an important evolution in understanding addiction. But then you see that hepatitis C changes the dopamine circuits to the point where the basal ganglia is the area of the brain that gets attacked when people have come down with Parkinson's. And these are movement and disorders. So there's increased Parkinson's in people, rates of Parkinson's disease in people who have hepatitis C. So yeah, it's fascinating reading.
Awesome. Thank you, Douglas. Thank you.
Thank you, Douglas.
And thank you
Thank
for listening,
It was so
everybody.
great. So much knowledge.
And yeah, so there is a cure. There is it's quite reliable, and like Douglas said earlier, it's something of a miracle cure because it is quite high success rate for the hepatitis C virus being cured. I also wanted to say that the treatment is covered, although I know that doesn't mean that it makes it any easier if someone does have hepatitis C and is trying to get treatment. Obviously, like what we are going to talk about a bit today and what Douglas kind of mentioned is there are certain barriers and certain hoops to getting treatment and tests, especially depending on where you're coming from. And like there's a lot of stigma around hepatitis C and just stigma in general. So that I think that too is something that we're going to definitely get into more today and is really important to talk about. And that's kind of why I put the picture there. 34% feel embarrassed about having hepatitis C. Obviously, I think that's just a random number. I feel like I think all of us probably carry stigma and shame for something or another, and I feel like it's just important to remember that when we're talking about anything. And and like Douglas mentioned, it is like the first symptom or most common symptom is fatigue. And, that a lot of the times can certainly be discounted as something else. The symptoms sometimes are hard to know if it is like hepatitis C or as he was talking about with some of the mental health stuff, a lot of the times it might get blown over or sort of just not talked about in terms of this and the hepatitis C virus. So I think that's really important as well to remember. And yeah, it's something that I think it's really important that we're talking about it here today, especially like I was saying with stigma. And I'm really glad that we're all here today to share our knowledge and share a little bit more about how peers and as allies, what everyone's doing to help aid the fight. I guess that's a word I can use, fight against this virus. So Yeah. Jenny, do you want to introduce yourself and continue on?
Yes, I'm unmuted. Okay. Yeah, I never introduced myself before. My name is Jenny. I go by she and her pronouns, and I'm a peer educator with the Peer Power Project. So I've been part of helping organize this and host all of our wonderful speakers. I am very much learning about Hep C. I have a basic knowledge, and I just realized I should actually probably get tested for Hep C. Like I'm definitely learning a lot, and just to acknowledge that my knowledge is limited here. I did want to touch on a couple of things. I have the definition of health literacy.
Sorry, your like chair or something is like making weird background noise. There's like there's like creaking. If you're not moving, it's like scratching on the floor or something. Yeah, I can't hear it anymore. Because when you were talking,
Yeah.
like if you're leaning over and like papers rustling or something, I don't know what it is. Sorry.
Okay, no, that's okay. I should probably talk slower anyway. Can you still hear it? Okay. Health literacy, so I'll just read the definition out. It's the degree to which individuals have the capacity to obtain, process, understand, and act upon health information and services needed to make appropriate health decisions. And what I learned from Katie is that 60% of adults do not have health literacy to make pro-health decisions in terms of Hep C, which is a really big number. And I feel like there's actually a lot to break down within that statistic. So I thought I'd just ask if anyone wants to share, does anything stand out from this definition or health literacy or that statistic? I can annotate as well. I kind of write it on the screen. And if you'd like to share anything, you can put it in the chat. Unfortunately, I can't see the chat, so Sage can read it out if you put it there.
Monty said empowerment through health literacy.
Okay, I'm gonna put that in here. Empowerment. Awesome. Thank you, Monty. Thank you. Yes, I agree.
I think like education definitely is a thing that stands out for me too. Like just even in my own knowledge, I also was not familiar with this topic so much before doing some research, and like just how much there is to know, I think, about anything. Like you, even just if knowing the basics sometimes like might not give you a clear picture about something. And I think that's what stood out too from yesterday, like during even like everyone's talk, but like during Serafina's talk especially, and Janice's as well. Sandy said, process, then take action. One must accept the facts in order to choose appropriate treatment. And
you say that again?
Yeah, process, then take action. One must accept the facts in order to choose appropriate treatment.
Thank you, Sandy. Yes.
And Douglas said knowledge translation, usually 7 years for research to reach public understanding.
Knowledge translation, about 7 years before it reaches
Public, yeah. Before research reaches the public understanding.
reaches. Okay.
And then Nicole said, thank you, Douglas. And then Nicole said, you can't be expected to make informed decisions about your treatment if you don't understand what is happening to you. Well said, Nicole. Well said.
Great.
And
Can you see what I'm writing?
yeah, it's working. You're doing it.
Okay.
And then Jesse said access and terms make it challenging, which, yeah, that's a really good point. The lingo, the language, and yeah, having that access. And then Ben also said, thank you, Jesse. And then Ben also said self-determination. And Mary Kay, yes, people need to have equal access to treatment and services. Exclamation point. Yes.
I agree. Awesome.
Wonderful.
Thank you for all your input. Any last burning words? I'll save this. Okay. Go to the next slide.
Clear your drawings.
Okay. Sorry. I'm trying to go back, but I cannot.
Go to the bottom.
It's not coming up.
Or clicking on your thingy, your desk keypad. There. There you go.
Okay, thank you. So I just wanted to make this point. What are the social determinants of health? These are the factors of our social and political systems that we live in that can create barriers for certain groups to access healthcare. So some examples in the image here: depression, poverty is a big overarching one. Colonization is another large overarching one. Stigma would be huge. So yeah, there's a few examples there, and I feel like from what I've heard so far, like we all have a pretty good understanding of how social determinants of health relate to Hep C. From what I learned from Katie is that seniors, immigrants, and Indigenous people are at the highest risk of contracting the Hep C virus. So with that in mind too, it makes me think, like, what are the social determinants of health for seniors, immigrants, and Indigenous people? And in terms of health literacy that would make that possible. So if anyone has any more thoughts on that, this is kind of another just discussion piece. And I can leave it open now. And if you have any questions about what I said, please let me know. I was kind of thinking too, how in healthcare systems, like I don't often see seniors, immigrants, or Indigenous people there as workers, like, or not as often. So maybe there's that kind of like, oh, I don't, certain groups don't see themselves reflected in the healthcare system, and that's another social determinant of their health. Just like that, not being able to speak the same language, perhaps.
Douglas said the loss of skills and the ability to sustain economically drops the determinants.
Thank you, Douglas.
And
just whatever. Okay.
Yeah.
Good stuff. Anything else that you've identified in your life? Feel free to share as little or as much as you want. After this, we're going to kind of talk about what we can do to address these social determinants of health and increase health care and health literacy for Hep C.
Yeah. So Monty's shared interconnectedness of determinants. But yeah, definitely intersecting is big there. And then Sandy shared people need to have their basic needs met first, such as housing, food. Only then will they be able to take the steps to healthcare. And then Ben, yeah. And then Ben shared any barriers, including disabilities.
Thank you. Yeah, thank you. Yeah, I think this is just like such a big piece that might often get overlooked in the larger public eye about what are the conditions that actually cause this to happen. And those are like the very important questions when it comes to increasing healthcare, health outcomes. I'll save this and then clear it. And then go to the next slide. So yeah, just to keep the discussion going, wondering if in your place of work or in your experience with certain organizations, what have you noticed that is being done that is kind of helping those situations and increasing the health outcomes for people with Hep C? This could be something that's been done in the past or something that's being done now. Or also if you have any recommendations for things to be improved, or wondering if you'd like to share. Lots of questions. I know in Douglas's talk, if you're there, he's talking about the Cascade of Care and how people are lost at every step. Douglas, how many steps are there?
There's 5 probably at least, and then the other complications are what that I learned this week, like the complications with lab requisitions, where GPs or people who are not as knowledgeable get lost and lose weeks. So there's a presentation that Action Hepatitis Canada did last week on this show. There's a chart in there that shows every province has different barriers in that regard.
Thank you, Douglas. Ben mentioned that there needs to be increased accessibility for deaf, blind, and mobility difficulties, which is a really good point too for receiving care for sure.
Can you say that again?
Yeah, increase accessibility for deaf, blind, and mobility difficulties.
Yes. I'm glad you brought that up. Mm-hmm.
I know we were talking about peers being a part of things as well. And I know that there is some great stuff happening, but we got things coming in. Okay, being quiet. So Mary Kay, she said, we host a drop-in program, a little restricted right now, that offers testing, peer support, and hookups to community treatment programs. The drop-in will also have educational sessions on prevention and treatment. Yeah, awesome. I think the fact that a drop-in program is available is really important, because sometimes making appointments can be really intimidating and also hard. And then Monty mentioned that linking up with people with lived experience of Hep C to connect as peers to share info and experience. Totally. Yeah, that's really important. And then Jesse mentioned that that my dad was positive for 50 years before I got him to AVI. Taylor helped him to get his first fibro scan and a bunch of other knowledge. He had notions of info from previous doctors. Access to friendly experts isn't that common. Yeah, totally.
Mm-hmm. Common for, I don't know what to write really. Common for people to not have access to information.
Yeah, and like doctors only kind of giving you, it sounds like only giving bits and pieces really. I don't know if Jesse, you want to say anything more to that, but
bits and pieces. Yeah.
I'm glad that AVI exists. Yeah.
Yeah. So like giving, like having more information at the very beginning.
Nicole mentioned everything from distributing harm reduction supplies, condoms, clean rigs, etc., and explaining why they help prevent transmission to community testing days with incentives, and using those opportunities for educating about treatment, etc.
Yeah, definitely. Yeah, and I just think we live in a system that's it's like a scarcity model. It seems like there's never enough resources or like people to increase health literacy, which like sometimes it's a daily thing, you know, it's a daily practice of health. And if you don't have some support there every day to help like make decisions or understand info or help advocate, then like those are people that are really marginalized.
Yeah. Jesse also just said that like his dad not feeling safe with doctors, and that limited his access to info generally. So yeah, not feeling safe is totally a big thing. And yeah, Ben mentioning peer peers with you. Wow, that helps totally.
Okay.
Totally helps having some support. Accompany. Thank you.
Yes.
I think that just his feelings of not necessarily secure and safe with the doctors really probably, I think, impacted the doctors and their ability and willingness and interest in getting him, reasonable literacy or additional info. I'm pretty sure that he presented uncertain of their expertise, and they just limited how much they felt like sharing with him, if they had any at all.
Yeah, I think that's a really good point. Like the communication I feel like if doctors maybe, if they have some training in communicating with folks who might not feel safe too, that would really help that, and understanding their own selves within that too. I know that can be really challenging though, and obviously, yeah, there's probably a couple things going on, but I appreciate you that sharing. Thank you. I rambled.
Thank you, Jessie.
Thank you.
Is there anything else before we go to the next little bit?
We need to, Sandy did say we need to improve upon the stigma in our healthcare system from doctors and nurses. Yes. Gotta stop. Yeah. I think having more required education definitely around that. I don't know exactly what the education is like for doctors and nurses, but I have a little bit of idea. Sometimes things are available but not necessarily required. I know that like trauma stuff might not be required all the time, and things like that too, which might be really helpful.
Yeah, I agree.
That was
Thank you. Thanks,
awesome.
everyone. Thanks,
Awesome.
everyone. Here.
And then Douglas said, one-time testing for everyone to find those undiagnosed. Yeah.
Point of care testing. Is that what it's called? Am I saying that right?
Yeah.
Okay, thank you. Okay, so I think I might ask this question on the next slide. If there is anyone that identifies as Indigenous here that would like to share something, feel free. I found a couple of things. One of them's from the KD website. It's a report on how to increase health outcomes with Hep C for Indigenous people by creating space for Indigenous practices, languages, and culture, promoting self-determination and planning and delivering programs, engaging people with lived experience. So we've talked a lot about that. Destigmatizing programs and communities. Yes, but it involves anti-racist stuff. Create programs that are person-centered and respect for one's personal journey. So you can find this on the KD website if you're interested. And I found this other handout by the Native Youth Sexual Health Network, which is a national organization, as is KD, that does a lot of peer work with youth. So they did this project where they wanted to tell health professionals this. So this is a way to reduce stigma. They feel like there's some problems of stigma being perpetuated by a language that says like at risk or people that take risky behavior because it places the problem or the responsibility on the people taking those behaviors instead of looking at the systems that produce risk. So those social determinants of health like racism and organization that produce risk.
Sorry, your microphone, I think it's all staticky. I think it's when you lean forward, it like gets on your clothing.
Oh,
Yeah.
okay.
That's better. Yeah. Sorry.
Thanks.
We heard you. It just
You
was
heard
like,
that? Okay.
It was staticky, but yeah.
Okay. Thanks. So yeah, they're just with this handout there on the left, they wanted to invite conversation about what's some language that can be used that speaks more to the strengths of people than immediately saying these are people that are risky or taking risky behaviors. So I thought that was interesting. If anyone would like to speak more to this or what can be done for improving Indigenous people's health outcomes, that you're welcome to, or put it in the chat as well.
I think with dried blood spot testing, there's going to be more anonymity available for testing. You know, there's been research that has suggested that, you know, in smaller communities and First Nations women, single mothers or mothers are reluctant to, you know, to disclose what's going on because they risk having their children taken away. So, and that has been directly linked to an increase in Hep C and HIV infections.
Yeah, that's a really good point.
So with dried blood spot testing, you can just do it at home, and it's simple, easy peasy. Drop it in the mailbox and get your status back here.
Yeah.
Thanks, Douglas. What's the status of that? How available is that?
Yeah, so BC CDC is getting the equipment. They just got their, you know, so we're moving from phlebology, or whatever the word, blood tests to dried blood spot testing. And then there's still some stuff they need to do with point of care testing, which will give you your RNA status, right? So that's all coming in line. And as COVID starts to go into the background a bit, the speed of all this new technology is going to pick up over the year.
Thank you for sharing that. Thank you.
Jesse also said in the chat, stigma changes at risk into risky person is facing the risks rather than saying that they are in risky behaviors or living risky lives. So yeah, thank you for that. Yeah, that's a great point.
Thanks, Jesse. I'm just checking the time, so I might go ahead unless there's something else that really wants to come out right now. Okay. Well, I'd like to invite Monty to speak. Monty, are you here?
Yes, I'm here.
Monty's here. Great. Just because, yeah, I found out that Pan has done this amazing Hep C Leadership Project, so you can give us an update on that. I will stop my screen share, and I'm making you co-host.
I can do it too.
For some reason, I can't do that.
There you go.
Great. So
Co-host now.
Yeah, please share your screen.
Can everybody hear me okay?
Good.
Okay, sounds good. I sort of created the presentation as well to be slides to be viewed afterwards. I don't want to cut too much time into our lovely lunch, and this session has been so amazing for gathering community voice. That's awesome. I'm a person living with HIV, and at Pacific AIDS Network, part of their Positive Leadership Development Institute, or PLDI. I'm a trainer in training. And then I'm also the Hepatitis C Leadership Project Coordinator. And I live part-time both on the Blackfoot territory here in Lethbridge, and I also live part-time in what's known as Vancouver. And just want to express I'm very grateful for the stewardship that Indigenous nations have demonstrated to the land and continue to, and that I've benefited from that as a white settler and recognized my future learning, and very importantly, the listening. And we're funded by the Vancouver Foundation, which we're very grateful for. And their vision is to build healthy, vibrant, and livable communities across British Columbia. And I do want to acknowledge the enormous amount of leadership that this forum has engaged and provided. There's different roles in leadership, as we know, especially in the context of our communities. So Sage and Jenny providing leadership from a facilitation point of view and being wonderful hosts, and Hermione's role of being here to support her team and representing AVI as a manager. And then everybody here as participants, our leaders as well, coming to the table and offering such amazing, insightful input that is just incredible. You've come to the table to support this forum, and that is absolutely leadership right there. Some of the key project activities in the project is engaging people with lived experience. It's encouraging peer relationships and community building. And some of you might be aware we're building a pilot leadership training program for people with lived experience. And during that program, we will be providing leadership skills development through that future program. The project also supports PAN advocacy and participates in collective advocacy. And in my role, I'm really trying to build interorganizational connections to strengthen a communication network that's so important as part of advocacy. So what's informing this project is an advisory committee, which comprises of myself and 4 people with lived experience of hepatitis C. And our work sort of, converges in the center of those factors there that we take into consideration. We also have a Tuesday peer discussion group that takes place at 3 p.m. And we have the advisory committee and guests that will come in to participate in peer discussion to share and learn from each other. We've done a bit of community surveying, and we've also looked at some existing needs assessment out in community. There's other leadership programs such as PLDI that we can, utilize the success of that. Of course, PAN staff and community collaboration. I'm asked the advisory committee, a few months ago, what is meaningful connection to them as being part of the advisory committee for the leadership project. And the most popular answer was connection. So as the coordinator, I listened to that and try and create a stage for them that allows for their connection. This is a collaboration that I did with the BC CDC and then sent it out to community members for their input. So this could tie in with the health literacy. I thought it was important that there needs to be like a summary infographic of the various testing modalities for hepatitis C, which community can then use this as a tool to communicate to community members or their peers. And so I'll be putting that into an official blog post at PAN and then sending it out and doing it by email as well. So people are more than welcome to share this around. So the future hepatitis C leadership program. So the program is within the project, and it's an opportunity for people with lived experience of hepatitis C to come together exactly as you're doing here as peers to discover who they are as leaders, develop their leadership skills, and gain awareness of the important role that we know that peers play in the community. And we really will want to create a training space that's inclusive, diverse in participants, accessible, and empowering. So, depending on our lovely friend, COVID-19, the program will either be delivered in person, which will be 4 days, or it'll be delivered online. And Pan and I are going to assess, towards the end of March, what that picture will look like. So it'll either be in person or online. In terms of the curriculum, a while ago, the advisory committee and I were talking, and, the curriculum will have a content that, might look like that pie chart a little bit, where a good part of it is about connecting, and a good part of it is about self-care and personal development. And also that in community involvement picture, for things like advocacy and getting more specific skills to, say, become a peer navigator or a peer support worker. So I've been working on the curriculum, and so we'll be providing interactive exercises and group activities, and sharing through discussion, and compiling some take-home resources, and sort of going from, creating a space together to discover leadership, and then arcing over to applying and experiencing leadership by the end of the program. So here's some successes and challenges, for the project. There's a real offering availability for engagement and participation of people with lived experience. And then on the challenges side, there is so many opportunities for peer these days, but for those already kind of involved in community work, like the people on the advisory committee, people kind of have their own lives and they're already busy. And so sometimes that energy to put into the project, it could be higher, but, that has nothing to do with their intentions, because people's intentions are just great. And, it'd be great if we all had the energy to participate at 10 tables, but, such is not the case. And so maybe I'll just read off that last one on the challenges side. I probably won't get my wish of, I want community superpower to be able to instantly absorb and effortlessly apply, all the knowledge related to the needs for change for hepatitis C, but I'm kind of limited as an individual with my own learning, right? So that would be my wish, is just to effortlessly be able to implement it all would be fantastic. Please feel free to reach out to me if any of you have lived experience or know of somebody that has lived experience of hepatitis C to participate. Again, our peer discussion is at 3 p.m. on Tuesdays. Look for the applications for the future leadership training pilot program. They should be available in February. And please subscribe to the PAN newsletter to keep up to date about when that leadership training is going to be happening. So thank you so much. I probably wanted to get that shepherd's hook out, right? Wasn't he on mute yesterday? We liked it better like that. No, just kidding.
No. That was awesome.
Thank you
so much. That was awesome. If you want to share, maybe if you wanted to share the slides, you could email them to me, and then I can forward them along or any of your contact info or anything that you want folks to know. So thank you so much for that. That was awesome. Oh, this is great. So I'm just looking at the time. I'm thinking maybe if there's some questions or comments that folks want to share for anybody here, or just in general, that would be awesome. And then I guess we'll take our break for lunch after. But yeah, if there's any wonderful program, Monty. Amazing work, Monty. Great. That's awesome. Yeah. Any comments or questions? That would be awesome.
I hope this starts after the school year. So for us who are still pushing through our education,
would that be end of May, Douglas?
Yeah. I usually don't have exams, but like April, end of April, I think.
Right. We're aiming to have the actual program probably in June.
Cool.
Yeah.
Monty rocks. It's a good one. Yeah. Super exciting.
Thank you for that update. That was incredibly helpful.
You're very welcome. I'm so glad to be here, and thank you.
Thank you.
Thank you.
Okay. What are you thinking, Jenny?
Am I thinking?
Yeah. Should we break for lunch?
What? Yeah, sure. Is that what everyone else is thinking?
Is it lunchtime?
I hope you stick around. We have some
Yeah.
more sweet talks coming on, some documentary screening, some
Yeah.
creative writing with Sandy, who's here right now, who's part of our Peer Power project. So stick around. We'll see you at 1 o'clock.
Yes. Yeah. We'll keep it open. Awesome. Okay. Thank you, everybody. Thank you so much. We're
4
going to come
o'clock.
back.
Sorry. 4 o'clock, Ben. Yes.
Thanks. See you at
Yeah.
1.
See you at 1. See you at
Okay.
1 BC time.
Yes.